My name is Giuseppe Mancia. I am Emeritus Professor of Medicine at the University of Milano-Bicocca and the organizer of this meeting of the European Society of Hypertension. Meetings of the European Society of Hypertension are held every other year in Milan. Adherence to treatment has been and is one of the most popular arguments nowadays. This morning there has been a topical workshop at the meeting devoted to adherence to hypertension. It is a devastating problem for hypertension indeed, because it is clear that antihypertensive treatment is not taken regularly by most patients. Low adherence to treatment is more the rule than the exception. And unfortunately, there is a close relationship between adherence to antihypertensive treatment and cardiovascular protection. The better is adherence, the greater is cardiovascular protection. If adherence is low, patients are not protected as they should be. This morning, this was discussed in detail, the way adherence can be measured and the consequences of low adherence for cardiovascular outcomes. Now, for clinical practice, physicians have a serious problem with adherence because there are no good, cheap, and easy ways of measuring adherence. Unfortunately, what the patient tells the physician is not always reliable. And so some other measures have to be used, and research is trying to help physicians in having easy measures of adherence to be obtained at the patient bedside, but still with not full success. I believe that adherence will become even more important in the future because it is poor adherence, the factor which is mostly responsible for poor rate of blood pressure control worldwide and poor rate of lipid profile control worldwide. European guidelines on hypertension have always taken a liberal position on which drugs to be used in hypertension. 5 drug classes have been regarded as suitable for initiation and maintenance of antihypertensive treatment. Diuretics, angiotensin receptor antagonists, beta blockers, and ACE inhibitors and calcium channel blockers. And you can see that beta blockers are included at variance from other guidelines. And the reason for this is that these 5 drug classes, including beta blockers, have evidence of effectiveness in reducing blood pressure, and the benefit of treatment largely depends on blood pressure lowering per se, evidence of protection from placebo-controlled trials, and by and large a similar degree of protection in comparison randomized trials. So, according to the European guidelines, beta blockers are still part of the most important aspects of the treatment of hypertension.